Okay, we're gonna take a little break for a second, and from me anyway. And before we go to kind of the next section and maybe some review of some of the comments, we have two questions from two special guests. The first question will be asked by Valerie Tranim, who some of you may recognize from our ASH coverage. Valerie has been a myeloma patient since 2015. In addition to leading a support group in her home of Aurora, Illinois, she leads the Myeloma Crowd Community African American chapter. And she also moderates our African American Facebook page. And then the second question will be asked by Kelly and Yeffet Smith from Rockground, Texas. Kelly's been a patient since 2018, and Yeffet, her husband, is her caregiver. So Valerie, do you want to come on and ask your question first? And then Kelly and Yeffet.
Sure. Thanks for the opportunity. So we know that in the Black community, talking about mental health is often stigmatized or even a taboo subject. Yet we know that myeloma patients face greater bouts of depression and anxiety that's associated with, just the myeloma diagnosis and it being kind of like an invisible disease. What are some of your approaches that like each of you are doing and also at your centers to address this issue?
Well, I think the first, that is such a good question. And I think the first thing is awareness of not only of myeloma doctors, but also of my colleagues that, myeloma, there was a study that was done by the cancer support community that found that myeloma, I think, is fifth or sixth among cancers that associate with depression. And that because it is a cancer of adults, I'm not gonna say older persons because as I get older, I get closer to that older group, but is a cancer of people that really are very cognizant of the stigma that goes along with depression. And so we address it. One important point is that a lot of patients won't talk about how they feel unless it is prompted by their physician. And so when I see patients, really all patients, but especially patients with myeloma, I make sure that I go through my checklist. Now, my review of systems always includes, do they have any nausea? Do they have any vomiting? Do they have any, peripheral neuropathy? How's their pain? And how's their mental health? And that, and I first may, get an answer that that may be a bit dismissive, but then I think as we build rapport with patients, that they then become more transparent about how they feel. But it's such an important point. And I think, one of the most important things that we do, I just taught the medical school on Friday evening. And I made sure to push this point to the medical students. You have to ask about your patient's mental health. When you have patients with cancer, the cancer accompanies, social emotional problems. You have to ask about that every time. And they kind of open their eyes real wide and are like, really, what about chemotherapy? I said, it's about that too, but you have to ask about it. So hopefully that'll carry through in their careers.
And yeah, I think, I agree completely with what you said, Dr. Cole. I think one of the key things that when the question was posed that was pointed out is that myeloma is quite different from many different cancers in that it's more considered of a chronic disease, and patients and care partners often face this prognostic uncertainty. There's this uncertainty about what the future holds. And in some sense, it's like waiting for the other shoe to drop, where you're thinking, when is my disease going to progress? When I'm going to need another therapy? And what will that look like? And that in itself can be associated with lots of anxiety. And so what we've done in our center is really not only taken an approach to really incorporate this in our clinical workflow. For me, especially as a geriatric hematologist, I screen for depression and anxiety routinely in our patients, but we also have protocols. We have myself and one of my colleagues have 2 studies where we're looking at when we conduct a geriatric assessment and patients screen positive for depression and anxiety. Dr. Chris Jensen is leading that effort to refer and connect those patients with services. In my own protocol, we're doing this, but not only with patients, but we're doing this with patients and care partners, and we're screening them to understand how myeloma as a disease really affects their day-to-day life, their quality of life, and their function and their well-being. And we're analyzing those scores in real time, and we are connecting those patients with the services and the support that they need.
I think the idea is, as providers, you're not treating myeloma, you're treating a person, the whole person who just happens to have myeloma.
I agree. Yeah.
I completely agree with Mark. So what I clearly tell patients where we screen, and it may not offer it to every single patient, but when there is a clear screen that is showing that they need some help. So I view this as a piece of a pie, and what I'm very clear about what I'm able to offer is only a part. It is just the disease, but there is whole life around it. And what the other team that I closely work with is supportive oncology, who provide the exact care that I may not be able to focus on, or I may not be trained in that aspect. So, but together we can fill in that whole pie. If the emotional aspect, the social aspect, if the pain control aspect, there are lots of things that the supportive oncology can provide, and I'll be providing the oncology care at the same time, so that fills in the whole pie.
Yeah, it's part of a whole. I mean, yes, every time a myeloma patient is going to get their labs run, it's stressful, right, Valerie? You and I know this. We all know this. So excellent question. Did you have any follow-up question on that, Valerie?
No, thank you.
Okay, thank you for that wonderful question. Okay, Kelly and Effet.
Hi.
Hi. Thank you for joining us.
Oh yes, thanks for having us. I mean, these are always fantastic. So, so our question is really around how you, in treating myeloma and your research, how you sort of avoid the pitfalls of race-based medicine. And so we're getting kind of that concept from Dorothy Roberts, who wrote Fatal Invention. And but the idea is that, pulmonary function, kidney function, bone density kind of has these different values for African Americans versus non-African Americans. The idea that, if you think race is a social construct, right, as opposed to biological, how you're addressing that. And also, even when we talk about clinical trials, being careful that these trials and studies aren't reproducing old notions of race in the view of genetics or cause of disease, and navigating that. So kind of an umbrella as far as how you account for those pitfalls of race-based medicine.
Okay, great question. Dr. Grant, do you want to go first? And then we'll go to Mark, and then Dr. Cole, and then Dr. Nuka.
Sure. So I think this is a really excellent question, and to really start, is the first part is being aware. You mentioned kind of thinking about things like the GFR or the kidney function that usually has historically had race-based cutoffs that have been kind of challenged within recent times. And I think as clinicians, being aware that these particular cutoffs or measures have have been put in place, and that whether or not they truly should be holding in 2022, I think we need to be very much cognizant about that. In terms of, whether or not how you factor in genetics, I think when Dr. Nuka opened earlier and talked about genetic factors, and then definitely stemming from their work that they previously published, their paper, one of the things is just not thinking that African Americans necessarily, or Black patients, have higher risk genetics, which is actually not true. And really just approaching each patient as you see them, and not really thinking of them in terms of like these racial categories would be my recommendation.
Okay, great. Thank you, Dr. Grant.
Yeah, and so I would just say, so race and ethnicity is one of many identities that each of us hold, and some of us might identify more strongly with that than others do. And it's important to not, as clinicians, providers, to not have a bias and think that this group I need to treat any differently. And you need to treat each patient, each person differently, because each person's going to have their own unique background, their own unique treatment goals and wishes. And really, by understanding that, you can actively treat that person and provide the best care for them versus the best care for a Black person or a white person or an older person or whatever identity you want to focus on. So that, like I said, that person, really the whole the conclusion of them is a unique individual you should focus on.
Yeah, I think that, it really comes down in 2022, it comes down to individualized cancer care. And that you have to end up abandoning the biasness. One way to abandon the biases is to be aware of my own bias when I walk into a room, and to be aware of some of the social construct biases that are built into the medical system. That medical care, United States, is really based on a European social construct, that how I talk to a patient, the language that I use, is really built around a majority construct, and that I have to be able to be flexible enough with my patients to be able to maneuver through different social constructs. And so, and to be aware of that not everyone who looks like me has the same culture as me, that everyone who looks like, who is Caucasian or who's older or who is of a different gender than I am, that I have to be able to be aware of that. I have to be able to put down any bias that I have and approach that patient individually. And going back to medical students, the funny thing is that medical students aren't taught that way. Medical students, and through medicine, we're taught to group things together, to group myeloma here, to group lymphoma over here, to group, women here, men here. And we have to, when we approach individual patients, we have to break all that down and approach that person on their terms. And I always tell the students and tell the fellows, when a patient comes to you, they're on my turf. I use my terms. I'm using on my time. You need to flip that script completely upside down and approach them on their best time with the terms that they understand. And you try to make my turf our turf, that we're working together as a team in treating the cancer.
Oh, great answer. Dr. Nuka, we'll let you end on this question, and then I have one more question for everyone.
So this is a great question. There are biological and social the parts. There's a huge complex interaction between both of these. I'll start with an example from the COMPASS trial. So it's a it's a COMPASS trial was a 10-year-old study that has enrolled 1,150 patients. And these patients have been followed with sequential genetic sequencing done longitudinally over time whenever the patients relapsed. One of the main things that these are all, again, exploratory to find out where exactly the disparities are and how could we gain the equity. So if you heard from Dr. Cole before about the translocation 1114 more common in the African Americans, I probably will use the same example in this data set. So one of my colleagues, Ben Barwick, has mastered this data set, and what he was able to show was how did the African Americans do compared to the Caucasians in this data set. So what you see is sometimes I would say disturbing, because this is a controlled data set in known hospitals. The utilization of the triplets is lesser among the African Americans compared to the whites. So we all know the triplets are the standard of care, but yet they're not given. And clearly, when you see the age, one can say you use a doublet in an older patient compared to a younger patient. But the answer exactly is the opposite here. You're seeing African Americans presenting 5 years younger than the Caucasians. So you're seeing two things here. You're seeing much younger patients and more usage of doublets. That does not make sense to me when we look at this, but this is the reality. So now when the differences between both of these groups are looked at in terms of the survival, African Americans had lesser survival compared to the Caucasians. So then the deeper dive was done. Which are the groups that are having a lesser survival? So from what we discussed earlier, African Americans have lesser high-risk features, so they should have better survival. But clearly, there is not the right treatment that was given. So one can explain why there is lesser survival seen. But if you look at the non-translocation 1114 patients, so patients who did not have translocation 1114, the survival is equivalent across both groups. If you look specifically at the translocation 1114 patients, the survival is so less for African Americans. So more translocation 1114 people, less survival. So there is a drug. So one can clearly say access to care is a huge issue. The Caucasians are getting the drug, they're getting the survival benefit. African Americans are not getting the drug, they're not getting the survival benefit. So it is not a simple, straightforward question, but what I'm saying is there are biological components, the access to care issues, the social components, all play a part in this situation. And this example is a clear example of what we can do to gain that equity.
And that's an interesting example too, because that drug has not necessarily been approved in myeloma yet for the treatment of patients. So you might, as a patient, need to go push for that. And we've had patients do that, to say, can I get this off label, or can I get this in an expanded access program or something like that? And, you might not know that that's a possibility as a patient, and you might not know that much about 1114 if you have it. So, or that you even have it. So some of this is educating patients that not all myeloma is the same. Like it's this very extensive need for all types of myeloma education. Did that answer your question? And do you have any follow-ups?
Probably thousands of follow-ups. That was great.
Lots of follow-ups.
Very helpful. Yeah, thanks so much.
Okay, great. Thank you so much for joining us and for your question. Okay, I'm gonna just cover one more question. I know we're out of time, so it's time to go, but I think this is a good closing question. Kathleen is saying she just appreciates the efforts of HealthTree and other myeloma organizations as they've increased efforts to do more outreach to African American communities, to Hispanic communities, to rural communities or other communities that need greater support. So she said, we've reached out to primary care providers, federally funded health clinics, local hospitals, and is feeling like in that support group that her efforts are not going where they, supporting patients as she wants to see them supported. So when you think about outreach to, like, as a patient advocate or a patient peer or somebody who just wants to help their fellow myeloma patients, how do we best go about supporting this effort? What are some of the most effective things that we can do as advocates to help include everybody in better care? And I'll close with that question. So, Dr.
So I'll start. And-
yeah,
and
okay.
I know it's a topic we've talked about many, and part of it is participating in research by joining things like the I'm sorry, the cloud one that that the myeloma crowd has. I forget the name off the top.
Oh,
of my
so
head.
ours is called the HealthTree Cure Hub. Yep. Mhm.
Yes, the Cure Hub. By joining that, by entering your data, you're allowing researchers such as myself and the other panels here to look at data of yourself and other participants and be able to generate new ideas for new treatments, to identify patients that aren't doing as well as others with the current treatments and need additional help. So by allowing yourself and finding areas to contribute in research, you can help not only yourself, but help every patient with myeloma today and every patient in the future who might get it.
Okay, great suggestion. Okay, Dr. Nuka, and then Dr. Grant and Dr. Cole. You'll finish this out.
First of all, I'd really like to thank the person who asked this question and clearly recognizing this as a problem and trying to come up with the plan. And as you understand, this is not nothing happens overnight, and this is an effort that continues to be happening. It is a small incremental improvement is what the goal ultimately, to gain the ultimate goal. So if you're making that first step, that is a huge victory. So let's take it one step at a time. What you're doing is absolutely what I would do as well, bringing people onto the board with the common goal to gain exactly to make that next step in reaching. So I wouldn't have any other recommendations except keep pursuing.
Keep doing it. Okay, Dr. Grant.
I agree. I think, one of the biggest things that we see time and time again is that patients who participate in clinical research studies or share their experiences, whether it be in a therapeutic clinical research study or one of these real world registries, a lot of it is going to be the experience and a lot of word of mouth. So really kind of this idea of like respondent driven kind of sampling is what you think of in statistics, but essentially just saying, hey, if somebody's in a study and they've had this good experience, then they're more likely to tell somebody else. So I think just continuing the outreach efforts and just helping to spread the word as much as possible. And hopefully you can have more of that peer-to-peer encouragement to participate in research studies moving forward.
Okay, great. And Dr. Cole.
So I can give some perspective as when I first did my very first myeloma support group talk. It was in the basement of someone's house, and I used the old Kodachrome slides. There were 5 people there, and the newest therapy that I had on my slide deck, I ended with thalidomide. That's how long ago it was. So I think I was a first-year fellow. Fast forward, and I think there was one African-American patient. I clearly remember it. There was one African-American patient there. And I've carried this flag for, I guess decades now of trying to bring awareness of this disease to all people, but especially to African Americans. And in the talks that I've done, and the support group outreach has gone from 4 people to 20 people to now, hundreds of people. And now they're, and I applaud, you and what Valerie has done. If you would have asked me back then that there would be a specific forum for African Americans and myeloma on Black History Month, I would have pulled my hair out that I had back then, way back then. I would never have believe that that was possible. And so just like everyone said, I think everyone is invested in this. Every support group, every researcher. The fact that the FDA and the AACR met to address these disparities is huge, Things are changing, and it is blinding after decades of things being absolutely stagnant to now having forums like this. Is this the best gift I think anyone could have given me? Better than hair, better than anything that myeloma patients and African American myeloma patients and myeloma patients of all ethnicities are now participating, talking about this disease. And that's how it's going to move forward. That's how it's going to move forward, is by all of us talking, meeting, and pushing the needle forward. So thank you so much for what you do.
Well, I agree. And I want to do a shout out to Valerie because she started this Facebook group, and now we have 600 African American patients in this group. It's amazing. So thank you, Valerie. And we have just hired on an African American director for our program. So, you're going to see more coming from us to address this, but we're just so appreciative for everything you do. And before I thank you all, I need to just say that our next program will be live in Houston, Texas on Saturday, March 26th. So if you live in that area, we will feature a close look at myeloma research, focusing quite a bit on MD Anderson Cancer Center. So we hope to see many of you in Houston, and we will be webcasting that live. But for all of you, Dr. Grant and Dr. Cole and Mark and Dr. Nuka, thank you so much for joining us today, for sharing what you're doing. I think we've moved beyond now like studying the problems, and we're moving into what are we actually doing about this. So thank you to you all. It's very informative discussion today, and we just appreciate you all.